Good evening, everyone. So welcome to Mahamana Case Discussion Series. And today's topic is on salivary gland cancers. And I would like to invite Dr. Mitali Dandekar. She's a senior consultant and head and neck surgeon at Paras Hospital, Patna. And she'll be speaking on prognostic factors for overall disease control in patients with salivary cancers.
So good evening, everyone. And thank you so much, Aseem, Sunena, and Komal. So the topic I have been allotted and have been asked to speak on is prognostic factors for overall disease control in patients with salivary cancers. So as opposed to the more common oral squamous cell carcinomas, we know that the salivary gland carcinomas are rare. They make up not more than 5% of all head and neck cancers. They are varied. They have varied histology, and hence the data that is available is largely heterogeneous. Also, this makes a lot of the TNM staging quite redundant as far as prognostication is concerned. Also, not just primary tumors to the salivary glands, particularly the parotid gland is subjected to a high incidence of secondaries. With all this in mind, we must understand that the data that we have as of today is largely retrospective. Why do we need to prognosticate salivary gland cancers? To determine extent of surgery, to determine the need for neck dissection as well as adjuvant treatment, and most importantly, to understand the overall impact on locoregional control and survival. Let us get some things clear before we actually progress and proceed to discuss articles in detail. By T3, T4 cancers of the salivary gland, we mean locally advanced disease. And according to the AJCC classification, T3 tumors are the ones who are larger than 4 centimeters and those with extra parenchymal extension. By extraparenchymal, it means there should be clinical and macroscopic, not just microscopic extraparenchymal extension. Additionally, T4A and T4B disease encompass those which invade the skin, mandible, canal of the ear, and or the facial nerve. And the very advanced are the ones which go and invade the skull-based pterygoid plates or the carotid artery. By varied histologies, we mean, according to the WHO 2017 classification, histologies were varied as we know, the most common being the mucoepidermoid, followed by adenoid cystic, acinic cell, clear cell carcinoma, basal cell, intraductal carcinoma, salivary duct carcinoma, myoepithelial, epithelial myoepithelial carcinoma, pleomorphic adenoma, secretory carcinoma. Of the adenocarcinomas, the 2022 WHO has made several changes with regards to the clinical, histological, and the genetic performance of the adenocarcinomas. We'll dissect them a bit later. Additionally, in the 2022 WHO, the benign soft tissue lesions and hematolymphoid tumors have been removed. So the update largely encompasses clinical, histological, and genetic information. So amongst the adenocarcinomas, they have been further reclassified into sclerosing microcystic adenocarcinoma, which has a better prognosis and largely reported from minor salivary glands. The cribriform adenocarcinoma, which has been subclassified from the polymorphous adenocarcinoma, is known to have a higher risk of lymph node metastasis. And this is with this classification or subclassification is based on certain point mutations. Microsecretory adenocarcinoma and mucinous adenocarcinoma also show a distinct histological as well as genetic profile. With this, we can also differentiate the good salivary tumors versus the bad salivary tumors. Amongst the high-grade histologies are the adenoid cystic, salivary duct carcinoma with a higher incidence of nodal distant mets as well as cranial neuropathy, with a 5 years overall survival less than 50%. High-grade mucoepidermoid carcinoma with a 5-year overall survival again between 40 to 50%. Carcinoma pleomorphic adenoma, again a dismal 5-year overall survival. Squamous cell carcinoma again falls somewhere in the same range of 50%. Additionally, myoepithelial carcinoma, sebaceous adenocarcinoma, carcinosarcoma, and as well as oncocytic sarcoma are known to have high-grade histologies. Among the good histologies, or the ones which perform better, are the acinic cell carcinoma, low-grade mucoepidermoid carcinoma, clear cell, basal cell adenocarcinoma, and the lymphoepithelial cell carcinoma. With this background, what I plan to do is dissect some pertinent or important literature that exists, again, largely retrospective, but some of which have made an impact on the way we manage salivary gland carcinomas as of today. The first article that I shall be dissecting is by the MSKCC group by Spiro et al. From 1986. They discussed a 35-year experience with upwards of 2,800 patients of salivary neoplasms. It encompassed both benign as well as malignant tumors, of which 1,278 were malignant tumors. Amongst the malignant tumors, if you see the first table, the parotid gland formed the most significant weightage for all sorts of malignancies which they had in their database. After parotid, palate formed the highest incidence of salivary neoplasm, salivary malignancies, followed by submandibular and minor salivary gland. They assess the impact of site, histology, grade, as well as tumor stage on survival. If you can see this Kaplan-Meier curves, it suggests the survival in patients with malignant tumors, and it differed significantly according to origin. As we can see, the tumors which arose in by this tumors, we mean the salivary gland carcinoma. The tumors which arose in the parotid gland, the palate, other mouth sites, that is the minor salivary glands, did perform better, whereas the prognosis was less favorable when they arose from the submandibular gland, the nasal cavity, or paranasal sinus tumors. The ones which arose in the larynx, the minor salivary glands, had the worst or the lowest survival. Additionally, they also looked at various histologies, and as expected, actinic cell carcinoma performed better, as well as mucoepidermoid carcinoma. The ones which performed poorly were the adenocarcinoma, malignant mixed tumors, adenoid cystic carcinoma, and squamous cell carcinoma. Again, as expected, the ones with stage 1 disease and the ones with low-grade histology performed better than stage 2, stage 3, and intermediate and high-grade tumors. In adenoid cystic carcinoma, as stage 1 disease, more than 90% of the patients survive for 10 years, whereas stage 2, 65% patients, while stage 3, 22% patients survived at the end of 10 years. Of interest is noteworthy was the fact that the survival benefit of these cancers diluted with time, that is more than 10 years, probably because of the high incidence of distant metastasis. The next article that I shall be dissecting is the one by Gilly Mandegi, the MD Anderson group, radiation oncology group. They looked at prognostic variables, particularly in parotid gland carcinomas. It was a retrospective review of 178 previously untreated or treatment-naive patients from their database of 30 years. The aim primarily was to analyze optimal surgical procedure and rationale for combined treatment. Actinic cell, mucoepidermoid carcinoma, and adenoid cystic were further graded into low, high, and intermediate. Additionally, salivary duct, undifferentiated, and primary malignant mixed carcinoma were considered as high-grade lesions. On performing a multivariate analysis, they found that presence of histologically positive nodes, presence of deep lobe involvement, and tumor size of more than 3 centimeters were important factors in locoregional recurrence. Of their database, 25% of the patients developed distant metastasis. Grade and tumor size were the key factors in the prediction of distant metastatic disease. The factors which were significantly associated with disease-specific survival were histologic grade, N+ disease, tumor size, and nerve invasion. So they categorized their patients into the ones which underwent surgery alone, that is the grade 1, grade 2 disease underwent surgery. Grade 1, grade 2 disease who underwent surgery with radiation therapy. Grade 3 disease who underwent surgery, and those which underwent surgery with radiation therapy. On looking at the various treatment modalities on locoregional recurrence, they found that the grade 3 disease treated with surgery and radiation therapy had better control.
Hello. I think Dr. Mitali has lost connection.
My presentation just halted or what?
Yeah, we lost you.
Am I in? Not yet?
You are audible.
Okay. So, were you all with me till now?
Yeah, we were there till now. You can
Okay.
share your presentation once again.
Oh, it's not shared?
No, it's not shared right now.
Okay, hang on, sorry. Is this fine?
Yes, yes.
I'm so sorry. So,
I think, can you go back to like one more slide?
hang on. This?
Yeah, you were here at that time.
Okay. So, as we know, arsenic cell, oh, somebody is messing around. But anyway, as we know, arsenic cell CA is a cancer with a good histology, a favorable histology, since neural affection and lymph node involvement are found to be rare. Overall survival rates approach upwards of 95% at 5 and 10 years and close to 90% at 15 years. However, despite that, there are some prognostic factors which are associated with decreased survival even in arsenic cell carcinoma. In 2013, a retrospective medical record review of 155 patients was performed of arsenic cell CA. And the outcome measures that were assessed were overall survival and disease-free survival. The variables which were analyzed were age, gender, size, margins, and adjuvant treatment. Females, the arsenic cell CA was found more commonly in females, and also females had improved survival as compared to males. Younger patients performed better than the ones who were more than 45 years. Size less than 3 centimeters performed better. Most deaths which occurred in arsenic cell CA occurred due to distant metastasis as opposed to locoregional recurrences. Thus, although favorable histology, these features must be borne in mind when one treats arsenic cell carcinoma. There was also a SEER database analysis which was performed between 1973 to 2009 to look at demographic trends in disease-specific survival in salivary arsenic cell carcinoma. The total number of patients which were analyzed were upwards of 1,000 of arsenic cell carcinoma, of which the demographic data show equal distribution, more or less equal distribution between male and female. Also, the age distribution was by and large similar between the elderly as well as the younger patients. Again, the performance of patients at 5, 10, 15, and 20 years in both males and females, although females did better, it wasn't statistically significant, but the performance was upwards of 90% even at 20 years in females and upwards of 80% in males. The table 2 shows the multivariate analysis, and it must be noted that the ones with poorly differentiated tumors had a 20-year survival rate of less than 50%. Also, undifferentiated tumors died of disease or were censored before 20 years. Thus, grade and distant metastasis influence survival. Fortunately, distant metastasis occurred in less than 15% of all patients. Also, long-term data of poorly differentiated tumors in such patients is lacking. Coming on to adenoid cystic CA, there was a large, one of the largest data which was presented by the MD Anderson group in 1995 to look at the influence of positive margins and nerve invasion in adenoid cystic CA. As we know, adenoid cystic CA have a high propensity for invading nerves as well as local infiltration. They have a high rate of focal PNI, but also large cranial nerves, which can spread to the skull base and beyond. PNI is associated with increased rate of local failure due to higher probability of residual microscopic disease at the edge or beyond resection margins. So they analyzed close to 200 patients. Most common site of origin was minor salivary glands. More than 40% patients in their group had positive margins. 28% had closed margins. Almost 70% patients had perineural invasion, and of which 28% had pathological evidence of invasion of a named cranial nerve. 5, 10, 15 local control rates were 95, 86, and 79% respectively. For those patients with positive margins, the 10-year actual local control rate was 77% compared to those without positive margins. As can be seen, the ones with positive margins performed worse as compared to the ones with negative margins and close margins. Similarly, they differentiated the perineural invasion into the ones which were directly into named cranial nerves as opposed to ones which were into unnamed cranial nerves. And they found that the ones, large cranial nerve involvement was associated with poor local control as opposed to the ones without large cranial nerve involvement. If one can see the propensity of, the prognostication of sight with regards performance of outcome, local failure, minor salivary gland, submandibular, and parotid gland were not statistically significant as far as outcomes were concerned, local control was concerned. Amongst those with failures, they looked at the percentage of failures with positive margins and those with nerve involvement. Minor salivary gland showed maximum failures with positive margins as well as nerve involvement. Among all failures of parotid gland, maximum failures occurred at the nerve. The Dahanga group also presented their outcomes and independent prognostic factors to look at the benefit of radiotherapy. 201 eligible patients were analyzed retrospectively. 75% were treated with a combination of surgery radiotherapy, while 25% had only surgery. 35% had surgery of the lymph nodes. 12 out of this had lymph node metastasis, resulting into an occult lymph node metastasis rate of 17%. Of interest is the last 2 points, that is high age, disease stages 3 and 4, and involved or close margins were independent factors with a negative impact on the crude survival, while factors with an independent negative impact on both disease-specific survival and recurrence-free survival were similar against stage 3, stage 4 margins and solid growth pattern. Again, locoregional disease was influenced by stage 3, stage 4 margin status, vascular invasion, as well as whether the patient received postoperative radiotherapy. Now, coming on to squamous cell carcinoma, primary squamous cell carcinoma are rare. One needs to differentiate them from secondaries and high-grade mucoepidermoid. Neuropathy and nodal metastasis is common. Again, looking at the SEER database analysis of upwards of 2,000 patients of squamous cell carcinoma of the parotid gland, the outcome measures which were assessed were demographic data, lymph node, parotid surgery, and radiation along with survival. They found that age more than 85 years, tumor size more than 4 centimeters, extraparenchymal involvement, and the presence of distant metastasis were independent prognostic factors on multivariate analysis. Also, compared to no surgery, surgery was associated with better 5-year disease-specific survival. Similarly, RT alone was similar to no treatment, thus concluding that in resectable cases, surgery offered best chance of cure. Carcinoma ex pleomorphic adenoma occurs in pre-existing pleomorphic adenoma. Malignant transformation rate, which is reported, is up to 10% over a 15-year period. The prognostic factors which have been studied and which have been shown to be significant are nodal metastasis, distant metastasis, capsular neural invasion, and as well as surgical margins. Coming on to genetic landscape of these salivary gland neoplasm, salivary gland cancers, considering the varying histologies, a lot has been explored as far as the genetic landscape of these tumors is concerned, but yet they have not been established. Amongst the ones which have been studied extensively as reported by Yin et al. In Cancer 2016, mucoepidermoid carcinoma, the ones which overexpress EGFR and HER2 are known to have a higher rate of metastasis and worse overall survival. which probably may have an impact, particularly in the intermediate grade mucoepidermoid carcinoma when one wants to decide between adjuvant therapy versus no adjuvant therapy. In adenoid cystic carcinoma, EGFR overexpression again is correlated with worse histological grade along with c-KIT. The ones which express EN1 and AQ1 had better survival. Among salivary duct carcinoma, HER2 and P53 are known to have worse survival, metastasis, and worse recurrence rates. HER2 positivity has been explored to look at the role of trastuzumab as in breast cancer. Androgen receptor positivity is known to have a favorable prognosis. As we know, adenoid cystic carcinoma portend a propensity for distant metastasis to the lung, even in early stage cancers. Almost 40 to 50% of these survivors have recurrent metastatic disease, and hence an interest has developed in genetic mutational studies. MYB, NFIB translocation is overexpressed. Also, expression of c-MET is associated with enhanced tumor growth and invasiveness, but has not been proven to have an impact on overall survival. It has been studied with almost 200 patients of adenoid cystic carcinoma, were studied by the MD Anderson group to look at the impact of overexpression of c-MET. And c-MET was overexpressed in upwards of 50%. However, there was no correlation of it with survival outcomes. In mucoepidermoid carcinoma as well, translocations that interrupt the Notch signaling pathway and other gene fusions are seen in low as well as intermediate grade mucoepidermoid. However, since they are also found in high grade carcinomas, they are not routinely recommended. Amongst the salivary duct carcinomas, as we know again, as we saw in the previous slide, they are associated with an aggressive histology. HER2 overexpression has been associated with poor prognosis, may be utilized for targeting in such cancers. Coming on to the impact of lymph node metastasis in salivary glands. As we know, presence of positive lymph node metastasis portends a poor prognosis. However, occult nodes have been seen to occur in up to 20%, particularly in high-grade and high-stage disease. END has been shown to offer better outcomes as compared to observation as far as disease-free survival is concerned. In adenoid cystic CA, occult mets have been reported in up to 24%, but it has not been found to alter outcomes significantly. While in high-grade mucoepidermoid carcinoma, it has been found to impact on outcomes, locoregional control. Thus, to conclude, prognostic factors mainly include T stage of the disease, N stage of the disease, and grade of the disease. Complete surgical resection with adjuvant therapy in high-risk categories achieve best control. Genetic landscape of salivary gland carcinoma is still evolving and yet to be established. Thank you so much.
Thank you, Dr. Mitali. I'll request who has put this line, they can just take it back. And I'd like to start the case discussion session now. And I would like to request Dr. Apurva Garg. He's a senior consultant head and neck surgeon at Vishesh Jupiter Hospital, Indore. Dr. Madan Gupta. He's a senior head and neck surgeon at Medica Hospital, Ranchi. And Dr. Ridhi Sood. She is an assistant professor at Kidwai Memorial Institute of Oncology, Bangalore. And for presentation, I would like to request Dr. Suddhasheel Roy. He is a fellow in head and neck surgery at MPMMCC, Varanasi.
Hi, good evening.
Good evening, Apurva.
Are all both our other examiners there?
I think Madan was there. And Ridhi, are you there?
Hello,
Yes,
can
yes.
you hear me?
Yes, yes.
Yes, sir.
So shall I start?
Yes, please start.
Yes.
Good evening, everyone. Today I am going to present a case of a parotid swelling. My patient, Mrs. S, was a 49-year-old female from Muzaffarnagar, Uttar Pradesh. She is a homemaker. She presented to us with a chief complaint of swelling in the left side of the face below the ear for 4 months. On further elaboration of history, she said she was apparently well 4 months back when she noticed a swelling just below her left ear, which was initially the size of a pea, and it progressively increased to the current size. The swelling is painless. There was no associated history of sudden increase in size or increase in size during or after meals. She did not notice any other swelling in the opposite side of the face or her neck. There was no associated history of fever. There was no associated earache or discharge from ear. There was no history of dryness of eyes or mouth. No history of generalized weakness or swelling anywhere else in the body. She did not notice any lesions in her scalp or face in this period of time. She didn't give any history of asymmetry in face or deviation of the angle of mouth or difficulty in eye closure. She didn't have any history of difficulty in opening mouth or change in voice, nasal regurgitation of feet, or difficulty in shoulder movements. She didn't complain of any pain or difficulty in swallowing. She didn't have any history of back pain, breathlessness, cough, coughing up of blood, pain abdomen. On eliciting past history, she was found to be diabetic for the last 1 year and was having tablet metformin 500 mg once daily. There was no history of hypertension, breathing difficulties, no major surgeries in the past, and no history of exposure to radiation in the past. In eliciting family history, she said none of her family members, first degree relatives, had history of cancers or similar illness. She didn't have any history of addiction of any sort. No drug allergy history was found. Bowel or bladder disturbances were not there, and she takes a mixed diet. Moving on to general examination.
Suddhasheel, so can you summarize your history, give positive comments, and enlighten on the differential diagnosis which you think?
Yes, ma'am. Ma'am, we have a 49-year-old female here who has the history of swelling in the below the left ear, that's a parotid region, for 4 months, which is a short duration. And there was on eliciting history, there was no history of pain, or there was no history of facial asymmetry, which proves that this is, if considered a neoplastic lesion, this is mostly a benign lesion. And I also elicited negative history pertaining to other causes like non-neoplastic lesions like sarcoidosis or Sjogren syndrome, which was negated. So probably she doesn't have a non-neoplastic cause of parotid swelling. And I also negated the distant metastasis or other cause like lymphoma in this negative history. So probably from my history, the history is pointing towards a neoplasm of the parotid gland, which by duration, it seems it can be considered malignant, and otherwise it can be considered benign in the points that it doesn't have any facial asymmetry or any pain associated with it, or any cervical any neck swelling associated with it. So at this point, I will keep from history, I will keep a benign neoplastic lesion of parotid as my first differential diagnosis, and then a malignant lesion of parotid gland.
Anything other than parotid you can think of in this area?
This can be level 1B or 2 lymph node as well.
Right. So always your history will point to the origin of the swelling, and also you have to, like how you were trying to look into the etiology of the swelling, like trying to elicit whether it is inflammatory or whether it is neoplastic. We can narrow down our diagnosis and lead us into examination. So if it is a nodal swelling, you have asked certain pertinent questions for the audience. Can you highlight? What about if it is a nodal mass presenting as a solitary swelling in the upper neck? What are all the things which are running in your mind? Some of the things you have asked in your history.
Ma'am, solitary level 2 or 1B node can be from distant metastatic nodal spread from any other skin malignancies which I have negated, or it can be solitary lymph node. Unlikely, but it can be a single lymph node as a lymphoma. It can present like that. I have also asked questions pertaining to that, like generalized weakness or swelling in anywhere else in the body. A solitary lymph node can be distant metastasis from any lesion of the oral cavity or oropharynx, which I have tried to elicit from history, like there was no associated pain in swallowing.
So basically, metastasis with unknown primary. Don't call it as distant metastasis. So a regional node, and your questions will be trying to ask, you will try to find out if you have any possible issues in the primary sites, which are draining level, basically level 2. So level 2 and tail parotid is a overlap area where it can sometimes you think that it is a parotid primary only to later find it as a metastasis of unknown origin.
Doctor, I want to ask you some questions regarding the epidemiology. As she is a female, so can you tell me what are the factors in females which can lead to increased risk of parotid gland of salivary gland malignancies?
Especially in females.
Yes.
So usually we see some tumors which have propensity in males, but otherwise gender is usually not considered a factor in parotid gland neoplasm, sir.
You are partially right, but I'd like to tell you that nulliparity and early menarche, these are associated with greater risk of malignancy in females. Okay, and there are also occupational hazards related to salivary gland malignancies. Can you tell me exposure of which metals leads to this?
So usually there has been a propensity of livestock industries. The exposures from alpha toxins from aspergillus has shown some propensity to parotid to salivary malignancies as a whole.
Yes, and apart from that, exposure to nickel and silica dust is also associated with increased risk of salivary gland malignancies.
Okay, sir.
Yeah, you may continue.
So I'll move on to general examination, sir. Our patient is a middle-aged female who was seated comfortably and was well oriented to time, place, and person. Her performance status was assessed to be ECOG 0. She had fair general condition, normal blood pressure and pulse at the time of examination. She had no pallor, icterus, clubbing, cyanosis, or edema. She had a BMI of 24.1. She was moderately built and well nourished. I did a short systemic examination for her. The S1, S2 was normally auscultable, and there was no added sounds in the heart. The respiratory system showed bilateral vesicular breath sounds and no added sounds. Abdomen was non-tender, non-distended, and no organomegaly was palpated. So I moved on to local examination. On inspection, I found that there was a single 4x3 centimeter well-defined swelling in the left infraauricular region with extension to the postauricular groove. The overlying skin was normal in color with no sinus or fistula. The opposite parotid region had no swelling and no visible lesions were seen in the face. There was no deviation of the mouth on smiling and the facial symmetry was maintained. On palpation, I found out that there was a single well-defined swelling approximately 4x3 centimeter in the left parotid region with irregular edges and surface. It was firm and non-tender. The skin over the swelling, the temperature was not raised. And there was an approximately 1.5 centimeter into 1 centimeter area of the skin, which puckered on trying to pinch it. The skin was fixed to the swelling. There was no fixity to the masseter muscle. I did an oral examination for the patient. She had a adequate mouth opening, and there was no bulge in the tonsillar fossa or the lateral pharyngeal valve. And the opening of the parotid duct on both sides seemed normal. The palatal movements were assessed to be normal, and the gag reflex was also normal. On examination of the neck, there was no palpable lymphadenopathy. No lesions in the face or scalp was seen on examination. The ear examination showed a normal eardrum. Facial nerve motor examination was done, which was within normal limits in both sides. And cranial nerve examinations, low cranial nerve examination was done, which was within normal limits. So to summarize my history and examination findings, we have a 49-year-old diabetic female who had presented with a left-sided parotid region swelling for 4 months. On examination, there is a 4x3 centimeter firm, non-tender swelling in the left parotid region with fixity of the overlying skin, and there is no palpable lymphadenopathy.
So what do you think now, Suddhasheel? What is your provisional diagnosis at the end of examination?
So, ma'am, at the end of examination, my provisional diagnosis has changed to most probably a malignant etiology neoplasm of the parotid region.
Right. Yeah, so now how do you want to stage it?
Ma'am, I have not yet done any imaging till now.
Clinical staging you can give based on the size and the regional fixity of the skin.
Yes, ma'am, it is a T4A lesion, N0.
Why do you say it is T4A?
Because ma'am, skin involvement makes it T4A.
So you have two things now. So one is the tumor size. You have a 4 centimeter tumor,
Yes,
and indicators of extraparenchymal extension. Your facial nerve is normal and your regional nodes are not palpable. So you can give a provisional staging at this point. So how would you like to proceed now?
Ma'am, I'd like to investigate the patient starting with a USG guided FNAC of the lesion.
Okay.
And based on the findings of the FNA, I probably like to go ahead with a cross-sectional imaging with a contrast enhanced MRI of the face and the neck.
Okay, so now you are showing that FNAC has come as Milan 5.
Yes, ma'am.
So how do you stage what is the classification based on FNAC of the parotid neoplasm? How do you classify parotid neoplasm based on FNACs?
Ma'am, there are 6 grades in the Milan classification. Grade 1 is non-diagnostic. Grade 2 is non-neoplastic. Grade 3 is atypia of undetermined significance. Grade 4 has A and B. A is benign. B is salivary malignancy of salivary neoplasm of undetermined malignant potential. Grade 5 is suspicious of malignancy. Grade 6 is malignancy.
Right. So this here we are fortunate to get a straight diagnosis of a category 5, which is suspicious of a mucoepidermoid carcinoma. Question to you is, can you give a grading of the type of malignancy on Melan? Is there a provision for grading? And does that have any difference in your management?
Usually Milan, from FNA, mucoepidermoid carcinoma can be graded into low, intermediate, and high grade based on Brandwin classification or AFIP classification. And if for low grade mucoepidermoid carcinomas, which are if it is early stage as well, T1, T2 stage, our approach is more conservative. And if it is intermediate to high grade mucoepidermoid carcinomas, our approaches are more radical.
What will
I would
Milan category be?
Sir?
Suppose in FNAC it has come Milan category 3. What will you do?
So in atypia of undetermined significance, we can either go ahead with our repeat FNAC.
Correct. And
Or we can go for a depending on the scan, if there is involvement of only the superficial lobe or the deep lobe, we can go ahead with surgery as well, sir.
yeah, correct.
So Suddhasheel, the staging which you were telling is more of an architectural, you need lot of architectural information to grade the tumors. That unfortunately will not be given by your FNAC. Your FNAC can at max give the diagnosis into the type of malignancy, whether it is mucoepidermoid, whether it is adenoid cystic. The
Okay.
further grading, we need the histopathology final. The what you are telling, Brandwin or AFIP, those will be further on your final histology. Okay, so your FNAC will not tell you grade, but overall, some pathologies we know are high grade tumors and some pathologies we know are of low grade tumors, and that has a bearing on your further management. So what are the high grade malignancies in parotid, in salivary neoplasm?
Salivary duct carcinomas, squamous cell carcinomas, adenoid cystic carcinomas, not otherwise specified. Adenoid cystic carcinoma may be considered as high grade or intermediate grade.
Adenoid cystic carcinomas are considered high grade, whereas mucoepidermoid can be
high grade or low grade.
Or intermediate grade.
Yeah.
Yeah. So now next, cross-sectional imaging you were talking about. Do you have images?
Yes, ma'am. So, ma'am, this is a contrast enhanced MRI. This is a T1 weighted image, fat suppressed with contrast, and it shows enhancing lesion in the right, in the left parotid lobe, superficial lobe, which has also encroached the deep lobe. And there are also areas of necrosis which can be seen inside the lesion. This is the T2 weighted image, ma'am. which shows that there's a lesion in the superficial and the deep lobe as well. And there's hyperintense areas of necrosis or cystic-like spaces inside the lesion.
How do you tell, Suddhasheel, whether it is superficial or deep or both the lobes are involved on MRI?
Ma'am, usually we take the retromandibular vein as the indicator between the superficial and deep lobe in an cross-sectional imaging.
Right. So can you scroll up and down and show everybody the vein?
Ma'am, unfortunately, I only have
One image.
one image.
Okay. Okay. So on this, it is difficult to pinpoint at the vein, but normally, why is means why do we take up this vein as the division of, normally surgically, what is the division between the superficial and deep lobe?
Ma'am, the facial nerve.
Yeah, so normally we say that it is the fasciovenous plane of Patty which splits the salivary gland parotid into superficial and deep lobe.
Yes, ma'am.
So the vein traverses along the facial nerve to divide the gland into superficial and deep lobe. What else are you seeing in this image? Any local infiltration which will help planning your surgery?
Ma'am, it seems like there is infiltration of the masseter muscle.
Yeah, so that clinically you told it is free, but here it seems to be infiltrated by the tumor, and at places it is very close to the skin also.
Yes, ma'am.
So what are all the other things which you want to know from your cross-sectional imaging? Primary you told, so you are looking at the extent of primary local infiltration. What else in the primary you are looking at?
Ma'am, if we can also look for the neck involvement in cross-sectional imaging.
Primary, what else in the primary?
Ma'am, extent of the primary. What else?
So any infiltration into the external auditory canal.
Yeah, ma'am. Yeah.
We need to see the planes with the external auditory canal cartilage,
Yeah.
right?
Yeah.
And you were telling something about the neck. What do you want to see in the neck?
Ma'am, whether the lymph nodes are enlarged or not, we also look for that in the neck so that our management can be dictated by those findings.
Yes, so always you see the primary location, extent, and presence of regional nodes. Anything else now? You have seen the MRI, you have seen the extent, there are no neck nodes. What else you want to do in completion of the workup?
Ma'am, we should go ahead with doing a NCCT thorax to rule out any distal mets.
So for now, we don't know what is the grade of malignancy. If it's a high grade mucoepidermoid carcinoma, we would like also to rule out any distant metastasis.
Yes,
right. So next, how do you proceed now?
I want to explain the patient about surgery and go ahead with surgical planning of the patient by working up the patient for pre-anesthetic checkup.
What is the extent of surgery in this case?
In this case, my planning will be of a conservative total parectomy with skin excision and with neck dissection, elective neck dissection of levels 1 to 4.
So now first, let's discuss about the extent of parotidectomies. So how do you, what are the various parotid surgeries you know of?
Parectomies can be classified as superficial parectomy, deep total parectomy, and radical parierectomies, where we in superficial we only excise the superficial lobe. In total parierectomies, we excise both the deep and the superficial lobe. And in radical parierectomy, we also excise one of the other structures like facial nerve or skin or temporal bone or mastoid or ITF or temporomandibular joint. This is this one.
What is adequate parotidectomy?
Adequate parotidectomy is taking out the lesion with a cuff of normal tissue, normal parotid tissue, with resection of one of the main branches of facial nerve.
So in which pathologies that can be done?
In benign pathologies, which are very small and limited to the superficial lobe, away from the facial nerve, an adequate parotidectomy or extracapsular dissection can be attempted.
So what is the difference between extracapsular dissection and adequate parotidectomy?
Ma'am, in adequate parotidectomy, we do dissection of the facial nerve. In extracapsular dissection, we don't look for the facial nerve.
Yeah, right. That's good. Okay. So any newer classification systems you know of? Sorry, sir, you can ask.
Is there any role of frozen section here?
So we have seen that in meta-analysis by Schmidt that frozen can be can have a better sensitivity in telling the diagnosis of the primary more than an FNAC. So frozen can be used as a tool to diagnose on table, but it is sensitive. Its sensitivity is around 92%. Specificity is 99%. So it can be used if to see whether it's a low grade or a high grade mucoepidermoid carcinoma, and the decision on neck can be made. But in this case, most probably, whether this in this case the skin is involved, so probably we'll have to go with elective neck dissection anyway. So frozen might not help in this case.
Good. Yeah, ma'am, please continue with your question.
So Suddhasheel, I was asking you any newer classification systems you know of for classifying parotid surgeries?
Ma'am, there's an European classification of parotidectomies in which they have divided the gland into 5 regions, depending on a line drawn from the bifurcation of the facial nerve along the Stenson's duct and the facial nerve plane itself.
Yeah.
There is a superficial superior, superficial inferior, deep inferior, and deep superior, and accessory region. And depending on that, they have made a nomenclature system to define what all regions we have taken out. And if any extra structures have been taken out, they have to be mentioned after that in brackets.
Right. So now you told that you would like to do elective neck dissection in this case.
Yes, ma'am.
So on what factors does your decision of neck dissection depend in parotid malignancies?
Ma'am, it depends on firstly the stage of the disease.
Yes.
High stage diseases entail to more occult myths. So we can go. We have to go for neck dissection in this case. Also in high grade malignancies, occult myths percentages much higher. So high grade and high stage malignancies, we'll have to go for elective neck dissection in N0 neck.
Correct. So in this case, since your T stage is T4A, you would advocate an elective neck dissection.
Yes, ma'am.
What levels do you want to address?
In elective neck dissections, ma'am, I'll address level 2 to 4.
Right. Okay. So you have taken up this patient for surgery. Now, how do you want to proceed? What is your incision? What are your thoughts? How will you plan the surgery? What are all the things you are going to do in the surgery?
Ma'am, the incision has to be modified because of the involvement of the skin. So we have to try to incorporate the proposed exercise part of the skin inside the modified incision.
Right.
We'll proceed with neck dissection first, and then with the primary tumor, with the superficial lobe, the part of the skin will be excised, and then we'll do the deep lobe excision. And probably the amount of skin which has been excised will be closed by primary closure. We won't need a.
So how do you identify the facial nerve?
Ma'am, there are 3 pointers which we look at while identifying the facial nerve. We follow the digastric muscle towards its insertion. The facial nerve is approximately 1 centimeter superior to the digastric insertion. And we also follow the tragal pointer. The nerve is usually 1.5 centimeter inferior and deep to the tragal pointer. And there is also the tympanomastoid suture. We palpate it, and the nerve is 6 millimeters deeper to the is coming out from the sphenopalatine stylomastoid foramen. So these are the 3 pointers which we use in parotid surgeries.
Right. So intraoperatively, while dissecting the facial nerve, at one point you see that it is involved by the tumor. It is 360 degrees encased by the tumor. Now, what would you do? Pre-operatively, your facial function was normal, as you highlighted, but intraoperatively, when you are dissecting, you find it encased in the tumor.
There has been various studies which have shown that if preoperatively the nerve is functioning, so either we can go for a frozen section from the perineurium to confirm whether the nerve is involved or not. And if we don't have frozen section, we can still go ahead and sieve the nerve and not excise the nerve for margins, and plan for post-operative radiotherapy. Studies have shown that this has almost similar rates of local control.
Frozen section would entail the sacrifice of nerve, then only you will know. But sometimes your clinical examination, sometimes the nerve will be thickened, or it will be very firm, and this dilate means thickened. So that indicates the nerve involvement, and then you have to take a call whether if it is 360 degrees encased, most of the times oncologically it is not safe to leave the involved nerve there. And then to further confirm on your nerve margin, you can take the help of frozen section. Sometimes it is just adherent to the capsule, in which case you can still proceed in peeling off the tumor, provided that you are not causing the tumor to break and seed the surrounding tissues. Right. So you have any other questions by anyone else?
Yes. Is there any role of intraoperative nerve monitoring here?
Sir, there have been studies showing that nerve monitoring helps to improve temporary paresis of facial nerve. But permanent pulses, usually it has been shown that they don't make much of a difference. But in cases where there is a recurrence or a second operation is being done, which have violated planes, IONM can be useful.
So as you said, 3 landmark, but intra-op you are not getting 3 landmark. So what is the other option?
So am I not getting any one of them?
Yes.
So I don't have any idea, sir. Yeah, we can, so we can trace it retrograde. Yeah, from the
Yeah.
margin mandibular nerve, we can trace it.
Correct. So tell me the exact location of all retrograde position of like frontotemporal or vital buccal. Where does you will find? Any idea?
So marginal mandibular nerve is in the angle of the ramus in the subplatysmal plane. The buccal nerve usually runs with the Stenson's duct. So we can trace it from in front.
Not in front, but it's some little bit away from the duct. There is some distance, 1 centimeter, 1.5 centimeter. And that orbital branch you will get generally during the infratemporal fossa clearance. This nerve is high risk. So you must know the location of the orbital branch where it crosses at the zygomatic. Otherwise, you will injure the nerve.
Yes, sir. It's usually above the level of the zygoma, sir.
Yeah, so zygoma is a big length.
Yes.
You have to know the exact location. So in generally we draw a line from the lateral palpebral fissure to tragus. On the zygoma, okay, you where it crosses. Generally, we see that we find the nerve there only.
Yes.
Okay. So role of frozen section, you have told excellent all points. So one thing we can also think about the margin. So in role of frozen section, if suppose there is a big tumor, and if there is a deep lobe is also involved, and there is nearby structure, you want to know that you are getting R0 or not. So here frozen section also helps.
Okay, sir.
What is the intra-op complications?
The intra-op, there can be injury to the external carotid artery, and ensuing bleeding can be there, sir. Or intra-op, there can be facial nerve injury. And sometimes if we are going for a benign case like a pleomorphic, there can be spillage of the tumor, which is not a complication, but there can be incidence of seeding of the tumor from that.
Okay. So why this is important to prevent the seeding?
So from seeding, usually recurrences are there. So pleomorphic, it has a very thin capsule which is deficient in some parts. So spillage of tumor in pleomorphic is commoner than other tumors.
So there is one term pseudopodia. What is this in the morphic adenoma?
Yes.
What is pseudopodia?
Yes, pseudopodia is extension of the parenchyma through the deficient extension of the disease through the deficient capsule of the parotid glands. This looks like false feet, so it's called pseudopodia.
Correct. So why pleomorphic adenoma recurrence is high? So you will see pleomorphic adenoma recurs. The incidence is 50%, 10 to 50%. So why it is so?
So because of deficient capsule, sometimes the excision of the tumor might leave behind some residual tumor. That's one fact. Second is the seeding is also one of the factors. And sometimes less than adequate surgery can also be a cause of recurrence.
Okay. Anything more? So sometimes we see satellite nodule. What is satellite nodule?
So, which is satellite nodules are disease which is separate from the main bulk of the disease in the gland.
Correct. So we need to interrupt, we need to explore the all bed so that we cannot leave any tissue.
Yes.
Okay. And what are the post-op complications?
So post-op complications, again, we'll start with hematoma formation post-op, immediate post-op, or facial nerve paralysis, temporary or permanent. There can be Frey's syndrome.
Temporary, and what is the incidence of permanent?
So permanent incidence usually is very low. It's almost like 2% in the cases. The temporary is
Temporary.
so no idea temporary. How the percentage? I have no idea, sir.
Okay, so it is mentioned in literature 10 to. It depends upon surgeon to surgeon, but it's maybe it's up to 50%. Okay. Other complications?
So there can be Frey's syndrome. Or there,
How do you demonstrate the Frey's syndrome?
so by using starch iodine test. During feeding, if we put starch iodine on the parotid area, it will turn purple.
Right. And I'd like to add one more thing that interestingly, Frey's syndrome can be demonstrated in up to 95% of the cases, but around 30 to 40% of the patients may complain about it, but it improves generally with time. So this the examiners can ask you this. So just remember this.
Suddhasheel, you told that you will be doing a total conservative parotidectomy. Anything we see masseteric infiltration there. So you also need to incorporate the masseter in your resection along with your superficial and deep lobe with skeletonization of the facial nerve.
Okay.
That point we missed.
Yes, ma'am.
And since we were talking of Frey's syndrome, how do you surgically prevent the occurrence? Though we cannot, but anything you can do to prevent occurrence of Frey's syndrome? What is the precaution you want to take?
Ma'am, usually thick flap if it is raised below the
Right.
SMS level, it prevents development of Frey's syndrome. Otherwise, we can also.
What is?
First bite syndrome.
First bite syndrome can develop after parotid surgeries. So usually it is due to severing of the cervical sympathetic nerves. It is the patient will have pain while opening his mouth during feeding in the initial part, but it.
Where do you injure a cervical sympathetic nerve? Which location?
Parotid gland has supply from the superior cervical ganglion. Through the branches travel through the middle meningeal artery and the external carotid artery, sir. So during surgery, those nerves can be injured.
In which surgery it occurs? Does it occur in normal parotidectomies? First bite syndrome. Classically, it is described for which surgeries? Parapharyngeal space tumors.
Deep lobe tumors. Okay.
That is why sir is asking you, where do you injure the cervical sympathetic?
Okay.
So, if suppose you have injured the facial nerve or the facial nerve was involved by the tumor, what are the options in front of you to amend your, whether it oncologically resected or whether injured, what all you can do for facial reanimation?
Ma'am, we can go for cable grafting of the facial nerve on table.
Before cable grafting, anything else? End-to-end anastomosis. If nerve is suppose mistakenly you have injured, that also your mechanism of injury is important. If you are not losing a significant length, then you can do an end-to-end. End-to-end can be using the two stumps or using a cable graft. So what are the available options for cable graft?
We can use greater auricular nerve, or we can use sural nerve for cable grafting.
Okay. Then, other than cable grafting, what other options?
There can be, ma'am, static reanimation options or dynamic reanimation options.
Right. Okay.
For static, we can use slings like tensor fascia lata or temporalis fascia. They can improve the symmetry of the face, but they don't usually result in movement of the facial muscles. Or we can put in a sensate muscle as a dynamic reanimation option, like the masseter muscle can be used. Free gracilis muscles can also be used, ma'am. There's also an hypoglossal nerve jump graft, which can be done.
So you come to the masseteric and hypoglossal based on whether you have availability of proximal stump or not. So if you don't have a available proximal stump to reanastomose, then you have to use some other motor nerves which are locally available. Those can be either masseteric nerve or it can be the hypoglossal nerve.
Yep.
Other options, any just for completion's sake? You have told about free functioning muscle transfer. If nothing of these are an options, and we are looking at where the motor end plates have gone. So patient comes to you with a facial palsy which has been a long standing with no motor end plates available, then we do a free functioning muscle transfer using gracilis. Right. So if then we can come to you have operated this patient, you have histopathology report?
No, ma'am, the histopathology is still pending for her. We have just operated, I think 7 days back.
Okay, so what are all the things you are looking in the histopathology report? Let's imagine.
For this case, the primary diagnosis is also important, because sometimes
Okay, it is mucoepidermoid carcinoma, high grade. What else you are looking at? With these two things, what else you are looking in the histopathology report?
Ma'am, involvement of the adjacent structures will be important. The neck nodes which we have dissected, if they have metastasis or not.
Okay, neck nodes. So basically you want to know, one is the grade of the mucoepidermoid and what staging system they have used to grade the mucoepidermoid. What are the grading systems you know of in mucoepidermoid?
The descriptive systems like one proposed by Healy and one also from MSKCC. And the objective ones which we usually follow in our institute are either AFIP or Brandwin.
Why is it important, Suddhasheel, to know which staging system the pathologist is using? So Brandwin tends to upstage a tumor and AFIP tends to downstage a tumor. So suppose we are in intermediate group, and if the pathologist has used a Brandwin, we know that it is upstaged. So, and if it is an AFIP, it is downstage. Though, how does it differentiate in the planning the adjuvant treatment? First, you tell that for which grade tumors you want to use adjuvant RT, or in which tumors you would like to observe the patient.
Only in cases where there is a low stage T1, T2 and low grade tumors with no neck involvement, we can think
Let's limit to mucoepidermoid carcinoma.
with early stage T1, T2 and low grade mucoepidermoid.
No, we have a T4A tumor.
So in this, ma'am, we have to go for adjuvant.
Basically, in mucoepidermoid, for all high-grade tumors, we give RT. For low-grade tumors, we can observe if your margins are okay. Those, it is debatable because it was a T4A tumor with local infiltration. We would like to irradiate.
Yes, ma'am.
But basically, for intermediate, it is a gray zone. And that's where you want to know the type of staging system with the pathologist use. So for this, again, it is a multidisciplinary discussion and lot of opinions will be there from your colleagues. So you would like to discuss in MDC whether you would like to give adjuvant RT to this patient or not. For this particular patient, being a high stage tumor, you would like to give adjuvant RT. So it is a T4A. Let's take it as high grade and N0. You are planning adjuvant RT. Any role of chemotherapy in salivary tumors?
Before that, I'd like to ask one more thing. What are the other indications for giving radiation?
Sir, nerve involvement.
For parotid tumors in general, not pertaining to this case, but in general.
Sir, vascular involvement, nerve involvement. So neck nodal metastasis, high-grade tumors,
Right.
high-stage tumors.
Right. Any other? In some specific histologies where you should give.
Adenoid cystic, sir, usually we give.
Right. Also deep lobe tumors and recurrent tumors.
Okay, sir.
Okay. And also remember that sometimes for if the examiner can go into detail, so if they ask which tumor, in which tumor you will have the highest field of radiation. So in adenoid cystic, the field is kept more because it has perineal invasion.
Yes,
so
sir.
they even can go up to skull base.
Okay, sir.
Okay. Yeah. Ma'am, please continue.
Suddhasheel, you can answer about chemotherapy, any role of chemotherapy in salivary tumors.
For as far as adjuvant therapy is concerned with chemo, no prospective studies have come out yet. There is a study which is taking place from RTUG group now. The accrual will end in 2023 to 52 patients. They have compared adjuvant RT with adjuvant CTRT. Their results are still not there. For inoperable cases, chemotherapy may be used in cases of adenoid cystic carcinoma with targeted therapies.
Yeah, so unlike squamous cell carcinomas, we don't have clear-cut guidelines for use of chemotherapy. What we know is that we use adjuvant radiotherapy only. We don't have good evidence to suggest that we should use chemotherapy in an adjuvant setting. Whereas if you see your recurrent or unresectable or locally advanced unresectable or recurrent tumors, again based as Mitali ma'am was nicely highlighting, we need to see the genetics and use specific targeted therapies. Anything you know of particularly for mucoepidermoid carcinomas? Any role of targeted therapy in mucoepidermoid carcinomas?
Ma'am, exact molecule I don't know, but there has been studies of translocation of 11 to 19 chromosome, and there is the particular gene involved is CRTC gene and MAML gene. They're involved, but specific.
That is a mammary analog. Secretory carcinomas, not in the mucoepidermoid. As far as I know, I don't think we have any particular targetable agent in mucoepidermoid carcinomas.
Yeah.
Have you read about heavy ion therapy in parotid?
So, pardon me, sir, I couldn't get you.
So, heavy ion therapy. What is heavy? There is in parotid, especially in salivary gland tumor. There is other than conventional radiotherapy. There is other ion therapy like carbon ion therapy has been described.
Yes, a neutron radiotherapy has been described for adenoid cystic carcinoma, sir.
Yes. So, what is the advantage of this heavy ion therapy?
Sir, I don't know, sir.
Basically, it provides precise therapy with we can give higher dose with sparing of normal nearby normal structures, and we also can provide high radiobiological effectiveness. And it has seen that this therapy also act in radio-resistant tumors. So these are the advantages of heavy ion therapy.
Yes.
Which genetic mutations are more common in mucoepidermoid carcinoma of salivary gland?
So we T11-19 translocation, sir, is in mucoepidermoid.
And other are EGFR. Remember about EGFR also.
Okay, sir.
Sorry, it's a biomarker. Sorry, my mistake. Yeah, so those are also more common in mucoepidermoid. Okay. And any role of radical radiotherapy?
So in operable cases, operable cases with adenoid cystic, there is a good response with neutron radiotherapy. But
Right.
for operable cases, there's little evidence to go with radical radiotherapy.
No, I'm just talking about parotid tumors in general. Is there any role for radical RT?
So only I know of in adenoid cystic, we can, in inoperable cases, we can use neutron radiotherapy, and they have a good overall survival compared to other inoperable cases.
Yeah, mainly it is in unresectable tumors only, and we can use neutron beam if it is available. But unfortunately, we have only one machine in our country. So hopefully, we'll get more results when other centers also come up. Yeah. Any other examiner has any other question?
I think we have covered everything.
Any role of immunotherapy in salivary gland tumor?
Sir, I don't know, sir.
Some study has been done or is still going on, and maybe in future, maybe we don't know, there will be a role of immunotherapy. We'll see the coming study.
Yes.
And how will you follow up this patient?
So usually we'll call the patient in regular intervals of 3 months post surgery and after adjuvant therapy, and for general clinical examination, and if we have suspicious of recurrences in node or regional cervical node or locoregional recurrence, we can use some imaging to confirm, or image guided FNSC to confirm.
Okay, and which are the common varieties of parotid cancers which may have recurrences even many years after the first treatment?
The adenoid cystic is notorious for recurrences. Acyanic cell has also shown to have recurrence after a long period of time.
Right, and there is one more.
So polymorphous adenocarcinoma, I think.
Yeah, polymorphous low-grade adenocarcinoma, PLGA. Yes. Right, right. Good.
Role of targeted therapy.
So in inoperable cases, unresectable cases, we can use targeted therapy.
What kind of targeted therapy?
So like in adenoid cystic, we use imatinib for c-KIT mutations, and for acynic cell, we can also use trastuzumab in case of HER2 mutations for salivary duct carcinoma.
Excellent. Yes. And
for acynic cell also there is a mutation in VEGF C. We use axitinib for that. So.
Yes. Good. So one case scenario, if low-grade mucoepidermide with positive margin, what will you do?
So adjuvant radiotherapy.
Any study that support your statement?
So I don't know, sir, of any study.
There is one study has shown that if there is a low-grade mucoepidermide with R1, positive margin R1, we can observe, but it should be R1, not R2.
Okay, sir.
Yeah, Madan.
Hello.
Yeah, I think we can stop the session now.
Yes, sir. Yes.
Yeah. So anybody would like to make any statements or any comments? Anything that we need to discuss further or any points that we need? Or if there is any question on the chat box?
Methods to avoid Fraze syndrome.
Oh, yeah. That's fine now.
Okay.
Yeah, he answered it. Yeah, we can do muscle rotation or raise a thick flap. He did well. He did really well.
So thank you, everyone. Thanks a lot. Thank you, Dr. Mitali, for the excellent talk. Thank you, Dr. Ridhi, Dr. Apurv, and Dr. Madan. And thank you, dear friends, for joining. We shall be meeting you all once again on 7th of December. The topic will be oral carcinoma. So we'll be discussing the details by Sunday. Thank you. Thank you, everyone.
Thank you, sir.
So bye bye. Thank you. Thanks for the opportunity.